Assalamu alaikum, everyone. My name is Dr. Nuha Alzaabi. I would like first to thank Sanofi Enzyme, Dr. Osama, and Dr. Hatab to give me this opportunity to be speaker in this great conference. And thanks for everyone who are still awake and still listening to my presentation. I hope my presentation gonna be useful and beneficial. My topic today will be about the enzyme replacement therapy and its long-term effect. Okay, the outline of my presentation will include an overview about the lysosomes, its function, and also the anatomy. Then I will talk about the enzyme replacement therapy, its advantages, challenges, and then I will talk about specific enzyme replacement therapy of a specific lysosomal storage disorders. The lysosome, as you can see here in this photo, lysosome are single-wall membrane enclosed organelle that contains multiple of digestive enzymes. Those enzymes are capable to digest multiple polymers in the cells, including proteins, nucleic acid, carbohydrate, and lipids. So we can say that lysosomes are the digestive system of the cell, or we can say also it is the floating garbage of the cell. Now, what is the function of the lysosome? Endocytosis is one of the major functions of the lysosome, in which that there will be digestion of the molecules taken up from outside the cells. Phagocytosis is another important function of the lysosome, in which that there will be degradation and digestions of the molecules inside the cells, for example, the macrophages and bacteria. Autophagy is another important function of the lysosome, which is defined as a turnover of the cell, in which that there will be digestion and degradation of the all cell suborganelles, like, for example, the mitochondria. Lysosomes, as I mentioned, contains a lot of hydrolytic enzymes. There are more than 50 enzymes, and the mutation in the genes encoding those enzymes will result in deficiency or defect in the function of those enzymes, leading to more than 50 genetic lysosomal storage disorders. So what will happen in lysosomal storage disorder? There will be accumulation of unwanted substrate, which will lead to multiple of complications, like, for example, metabolic imbalances, widespread cellular dysfunction, through cell signaling, communication alteration, disruption of the lipid pathway, and downstream of autophagy processes. Let us just imagine that this is the lysosome, which is the garbage containing multiple of enzymes work to degrade and digest unwanted materials. If there is missing enzyme, what will happen? The garbage will not be able to get rid of those substrate, and this will lead to accumulation of substrate-filled lysosomes in variable tissues. Now, the inheritance. Most of the lysosomal storage disorders are inherited as autosomal recessive. So in each pregnancy, the risk is about 25% to have another affected child. There are exceptions. Fabry disease, MPS type 2, and also Danon are inherited as X-linked disorder. So the unaffected carrier mother has a 50% chance to transmit the disorder to her sibling, to her male sibling. Now the treatment strategies. There are different treatment modalities and methods which are FDA and approved, and still there are some modalities under clinical trials. Those modalities include gene therapy, substrate reduction therapy, enzyme replacement therapy, molecular chaperone, and also bone marrow transplantation. Let us now talk about the enzyme replacement therapy. Enzyme replacement therapy has changed the prognosis and the clinical manifestation of a lot of lysosomal storage disorders. They are being approved for multiple lysosomal storage disorders like Fabry disease, Gaucher, Bombay disease, acid lipase enzyme deficiency, and multiple forms of mucopolysaccharidosis. This slide just will show the names of the enzyme replacement therapy for each disorder, the date of approval, and the trade name. Now, what are the advantages of enzyme replacement therapy? Regular intravenous infusion of those recombinant enzyme replacement therapy has been used to improve the clinical outcomes of those patients. So there will be improvement in working ability, ameliorated respiration, and there will be improvement in the quality of life. But there are some challenges facing use of enzyme replacement therapy. One of those challenges include immune response and development of IgG antibodies. Those antibodies gonna produce in the cells in the body of the patient who's receiving enzyme replacement therapy. Then those antibodies will interact at the site of binding of the enzyme or of the ligand. Differently, there will be reduced uptake of the enzyme replacement therapy, and this may affect the treatment. The immune reaction depends on two factors, which are presence or absence of mutated enzymes, and also on a cross-reactive immunologic materials, which is called acromegastasis. I will talk about it when we will talk about Gaucher disease. Now, what are other challenges? Bioavailability of enzyme replacement therapy to a difficult pathological site is considered another challenge, especially the central nervous system, where the blood-brain barrier acts as a barrier for enzyme replacement therapy to reach different cells of the brain. Furthermore, enzyme replacement therapy may fail to reach the significant clinical improvement because of rapid degradation. Now, let us talk about specific enzyme replacement therapy to specific disorder. I'm going to talk about Gaucher disease and Gaucher disease. We know that Gaucher disease is a rare disorder, but it is one of the most common lysosomal storage disease. This disorder characterized by a very wide clinical presentation, ranging from severe prenatal form to very mild asymptomatic form. There are three major subtypes: type 1, which is non-neuropathic form; type 2 and 3 are a neuropathic form. The other two subtypes are very rare, which are the prenatal lethal and the cardiovascular form. Before 4 decades, the management of Gaucher disease was mainly supportive, depending on recurrent blood transfusion to restore cytopenia and also multiple complicated orthopedic procedure. But in 1991, there was a dramatic change in the natural history of the Gaucher disease and also in the prognosis, with the production of first placenta-derived enzyme replacement therapy, which is aglycerase, that has been replaced later with imiglycerase in 1994. In 2002, there was a production of substrate reduction therapy, which is miglustate. Glycerase and teleglycerase alpha are considered the newest form of enzyme replacement therapy. Now, what is the long-term effect of ERT? Regular intravenous infusion of those recombinant enzymes are proved to be safe, well tolerated, and effective in reversing the symptoms related to the visceral and also to hematological involvement. It's important to know that the interstitials, histological findings such as infarction and fibrosis may affect the response to enzyme replacement therapy. So it is very important to diagnose those patients as early as possible, to introduce the treatment as early as possible. There was a big study performed by International Collaborative Gaucher Registry. This study was focused on studying the effect of imiglycerase on a patient suffering from Gaucher disease. The target group was patients suffering from Gaucher disease type 1, receiving imiglycerase for more than 70 days. There was comparison in the response to the treatment at 3 different occasions. First, before starting the treatment, then after 10 years of initiating imiglycerase, and then 20 years after initiation of imiglycerase. This study focused on different parameters to see the response. Those parameters include hematological response, where the hemoglobin concentration and the platelet count was measured regularly, bony parameters to measure the bone pain and the crisis, visceral parameter to see the response to the treatment, and also orthopometric parameter to see the improvement in height, weight, and body mass index. Now, let us talk about the imiglucerase effect on hematological parameter. This study showed that there was significant improvement in response to imiglucerase within 2 to 5 years. This improvement was maintained after 10 years and throughout 20 years in both splenectomized patients and non-splenectomized patients. It is also important to know that in most splenectomized patients, the count of the platelets and the hemoglobin concentration were almost normal before initiation of imiglucerase. But with the imiglucerase initiation, there was further improvement in their concentration and count. Thrombocytopenia may persist for a while after initiation of imiglucerase, but this count will improve over the years with imiglucerase treatment. Now, what about the visceral response to enzyme replacement therapy? As Dr. Nadia Al-Hashmi mentioned before, almost all patients suffering from Gaucher disease are having massive hepatosplenomegaly. So with enzyme replacement therapy, there was a significant reduction in the liver size. However, the normalization of liver size does not exclude any other hepatological pathologies, like, for example, hepatitis, although those complications are very rare. What about the spleen? The spleen size usually normalized and improved significantly at 10 years post-ERT, and this improvement was maintained at 20 years. This is a photo of a girl who was diagnosed at age of 8 years with Gaucher disease. There was massive abdominal distension due to massive hepatosplenomegaly. 2 years post-enzyme replacement therapy, there was significant reduction in hepatosplenomegaly. Now, what about the skeletal manifestation? I need to highlight that the response to enzyme replacement therapy depends on the pre-treatment statement. So it is very important to start the treatment as early as possible. Children who were having already infarction, osteonecrosis, and osteomyelitis continue to have those complications despite the enzyme replacement therapy. But those children who were free from those complications and received enzyme replacement therapy continued also to be free of those symptoms. Now, the anthropometric parameters. This study showed that the enzyme replacement therapy improves the growth velocity. It also saw the children usually end with a normal adult life. Moreover, body mass index improved significantly with the imiglucerase, and the percentage of obesity among those affected children is almost similar to those healthy children. Now I'm going to talk about the effect of enzyme replacement therapy on Bombay disease. Bombay disease is also another rare disorder, but it is common lysosomal storage disease. It is caused by deficiency of acid alpha-glucidase enzyme, and this will result in accumulation of glycogen-filled lysosomes in variable tissues, including mainly the cardiovascular system and musculoskeletal system. It is very rare with a frequency of 1 to 40,000. But the neonatal screening initiated in Austria and also in Taiwan showed that the frequency of Bombay disease is much higher than what is expected. It has also very wide clinical presentation, ranging from very severe infantile Bombay disease with a lethal form due to very severe deficiency of alpha-glucidase enzyme to a late onset Bombay disease with a variable clinical presentation. Before 2006, Bombay disease was considered a lethal disorder with very poor prognosis. Usually children used to be ventilator dependent at the age of 6 months, and they never able to walk or to crawl. And eventually they die at the age of 1 year because of respiratory problems. But in 2006, there was a production of the enzyme replacement therapy, which is Myozyme, and approved by FDA, and it changed this nature of Bombay disease. Lumozyme was also produced to treat the children suffering from Bombay disease and who are older 8 years. But this age restriction was removed in 2004. Both of those recombinant enzymes are administered by slow IV infusion at a dose of 20 to 40 milligram per kg per dose, once a week, once every 2 weeks. I need also to highlight that children who receive a higher dose of Myozyme usually have better outcome and response. ECRAM status. It is I think all of us knows that enzyme replacement therapy should be initiated as early as Bombay disease diagnosed. But before starting the enzyme replacement therapy, we need to identify the ECRAM status, which is the cross-reactive immunologic material. People who are ECRAM negative and do not produce a cross-reactive immunological material tend to develop high titers of antibodies. And those antibodies definitely will block the uptake of enzyme replacement therapy. So if anyone is labeled as ECRAM negative, he should undergo a specific immunomodulative protocol in which that there will be use of rituximab or other immunosuppressive medication before starting the enzyme replacement therapy. Now, what is the long effect of enzyme replacement therapy? Studies showed if Myozyme or other form of enzyme replacement therapy has been started before 2 weeks, there will be significant improvement of cardiovascular and musculoskeletal system. But if the enzyme has been started before 6 months of age and before use of the ventilator, there will be improvement in the overall survival period and also ventilator-free period. Although the prognosis of Bombay disease has not been known, but it is obvious that people who are receiving enzyme replacement therapy have better cognitive outcome. And definitely there are some immunological reactions during enzyme replacement therapy, but those reactions are very mild to moderate in nature and can be manageable easily. I would like to show you here, this is slide. This is an adult who was diagnosed with Bombay disease. There is significant area occupied with the glycogen before the treatment, but just 6 months after starting the treatment, there was significant reduction in the area occupied with the glycogen. Now, in conclusion, the enzyme replacement therapy has changed the clinical course and the prognosis of a lot of lysosomal storage disorders. They improve the quality of life and decrease the mortality and morbidity. Early diagnosis, early initiation of enzyme replacement therapy are very important to achieve better outcome. And usually they are safe and well-tolerated medication. Thank you very much for your listening. And if you have any question, you are almost welcome.